us online.
Our next speaker would be Dr. Jyotirmoy Pal, MD in Internal Medicine, Professor of Department of General Medicine, RJ Kod Medical College and Hospital. Sir would be speaking about a case of 70-year-old male CVA memory disturbance with hypertension in spite of 3 drug therapy and BP is not controlled. Here you go, sir.
Hello, Dr. Jyoti sir. How are you?
Yes. How are you?
We are really
How are you,
missing you
madam?
here. Thank you so much for joining us online. Are you able to hear
I
us?
cannot get in.
Yes, sir, we could hear you.
Yeah, you are audible, sir.
No. I am. Please allow me to share the screen.
Oh.
Jyotida, namaskaram.
Namaskar. Madam, please ask.
Yes, sir. Yes, sir. We'll just allow you to share.
Now.
So just a second, sir, we'll allow you.
Hey, good afternoon.
Good
Co-host.
afternoon. Nanda.
Good afternoon, Jain
Nice.
sir. Welcome.
Good afternoon.
We are
good
missing
afternoon.
you
Great to
also
see
here
you
at
all.
Chennai.
Yeah.
How are
I
you,
am
sir?
missing you all.
Yes.
And I'm there watching the whole program.
Okay.
I thought that I'll say hello to Jyoti, my good friend.
Yeah, sure. Jyoti sir, you can actually
Thank
continue.
you, Mr. Arulaj, for inviting me in your prestigious GCDC program. But unfortunately, I failed to present physically, so taking the advantage of technology. My previous speaker very nicely described the issue of resistant hypertension. So my issue is to present a case how we can overcome the resistant hypertension, or the issue is when after giving medicines after medicine and increasing the dose, the patient is not getting the desired result. What is the issue behind and how the physician can overcome the issue? So let us see few cases. 78 years male with hypertension is on antihypertensive drug prescribed by his family physician. Hypertension not controlled, dose was escalated and reached to the maximum dose. Again BP was not controlled. Patient have osteoarthritis, taking NSAID off and on. Patient suffered from CVA 5 years back, taking anticonvulsant drug. Patient have purely sedentary lifestyle, having the vision abnormality, having the depression. So comprehensive genetic assessment is patient have hypertension, post CVA, depression and osteoarthritis. Case 2 very interesting. 84 years female consulted physician for hypertension, drug was prescribed, BP was not controlled, dose was doubled. Again BP was not controlled, third drug was added. Again BP was not controlled, dose of the third drug was added. On a fine morning, patient developed dizziness and fall on the ground and developed a hip fracture. Patient put on traction and osteoporosis was detected. So here patient have uncontrolled hypertension, osteoporosis, hip fracture. So in the both cases, the physician failed to achieve the desired goal of the hypertension and the patient have multiple comorbidity. The question is why the physician has failed to reach to the maximum desirable goal, or what happened to the patient for which patient become bed bound. Whether on part of physician we have some mistake or we have some knowledge gap or something in the patient side. So let us see in the next 10 to 15 minutes we see what is the patient's issue. As the patient is elderly, the elderly hypertensive is a special subject. It should not be dealt like a younger hypertensive patient. In USA, even the 70% elderly have uncontrolled hypertension, in spite of having so much nice facility of healthcare. Because of the following changes are typical physiological changes, multiple comorbidity, multiple drug interaction, because elderly used to take even 10, 15, 20 drugs at a time, socioeconomic factors. All these factors make the elderly hypertension evaluation and treatment a special subject. So what are the characteristics of geriatric hypertension? Geriatric hypertension characteristics are decreased vascular compliance, decreased baroreceptor sensitivity, increased salt sensitivity, increased total and central adiposity, and neurohumoral changes in the aging. These are the typical physiological changes that happens in elderly, for which the issue of hypertension control or mechanism or application of the drugs is something different from the younger counterpart. First, if you see the vascular changing, aging causes the stiffness of the artery. That is, the collagen is deposited and artery is stiff. So, very difficult to dilate the artery giving some drugs. This is number one. Number two is the decreased vascular compliance. So, there is a relative increase of the systolic pressure, increase of the pulse pressure, and in decrease of the diastolic blood pressure and lower intravascular volume because of the low capacity of dilatation. So, there is a pulse pressure is increased and minor changes of intravascular volume can lead to the hypotension. Number three, consequence of the decreased baroreceptor sensitivity. So, there is a lot of BP variability. Due to the lot of variability, most important is lack of beeping in the midnight. The beeping actually is a protective for physiologically for human beings that prevents or more catastrophic event that happen in the early morning. So, if there is a lack of beeping in the midnight, more incidence of CVA or hypertensive catastrophe in the early morning. So, there is a more early morning BP surge, there is a more postural hypotension, postprandial hypotension and orthostatic hypohypertension and also hypotension. These are the baroreceptor changes due to the baroreceptor sensitivity that leads to a challenge of hypertensive control in an elderly. Next, salt sensitivity. Elderly are very prone for the salt sensitivity, and minor increase of the salt intake can cause a lot of BP changes. And elderly often have a sedentary lifestyle, take a lot of fast food having the high sodium content. So, this also a very important issue when the physician do not get the desired result by applying maximum drug to the elderly, because many times we do not take the history of the food habit, what type of food the elderly is taking, whether that food contains lot of sodium or not. Neurohumoral changes, there is a decreased baroreceptor sensitivity, increased norepinephrine, increased renin activity and increased aldosterone activity. So, considering all these physical issues, the challenges that we face, these are the white coat hypertension, labile hypertension, pseudo hypertension, postural hypotension, secondary hypertension, resistant hypertension, polypharmacy drug interaction, non-adherence. All these issues make a geriatric hypertension a challenge to every physician. Let us see what are the issues. First is the white coat hypertension. What is this? Means when the patient will come to your chamber, patient BP is recorded high. But if you do the home monitoring, BP is often is normal. So, white coat hypertension, when you suspect, if without taking the home BP monitoring, if you apply the drug, going back home, patient takes the drug and develop the dizziness. So, this is indicator, and when you do the screening of the end organs, you will see absolutely normal. This indicates that patient may have white coat hypertension. So, and dizziness in the elderly is very catastrophic because most of the elderly have a osteoporosis. So, if the without understanding the actual BP, particularly at the home, if we apply the antihypertensive drug to the elderly, the patient can develop dizziness and fall on the ground and develop the hip fracture. That is very catastrophic for the outcome of elderly. So, white coat hypertension, every physician should suspect. Labile hypertension, sometimes BP is high, sometimes normal. This is called labile hypertension, but this should be treated as a persistent hypertension because the liability of the labile hypertension is almost same like a partial, like the permanent or sustained hypertension. Pseudo hypertension, very important issue. Often patient have atherosclerosis. So, when we suspect pseudo hypertension, when we inflate the cuff and the cuff pressure increase above the systolic pressure, we cannot roll out radial artery against the bone. But if we can roll out the artery, then we should suspect patient have significant atherosclerosis. So, in this patient, falsely BP may be recorded high. So, actual BP may be 140/90, but due to the atherosclerosis, pseudo hypertension, patient BP may be recorded such as 160/100. So without understanding pseudohypertension, if you go on increasing the dose, patient will develop one day dizziness and fall in the ground and develop the hip fracture. So understanding and suspicion of pseudohypertension very important in the elderly person. Postural hypertension, if you give too much of drug or particularly in the summertime, patient have dehydration, patient can develop the postural hypertension. Again, that is catastrophic for the elderly. Secondary and resistant hypertension, I will come later on. Secondary hypertension should be suspected in the elderly, particularly two issues. One is the drug interaction and another is the renovascular hypertension. These two issues is the most common in elderly. Resistant hypertension, when you do not get the desired result, it has a separate definition. 3 drugs in a maximum tolerated dose, and one should be diuretic. So resistant hypertension frequently we get in an elderly, and what is the issues behind and how we can overcome without increasing the drug one after one drug will come later on. Polypharmacy very important in every geriatric conference. Polypharmacy should be discussed, and we should minimize the drug. That is the de-prescribing should be practiced by the all physicians, non-adherents. Very important. Patient have memory disturbance or patient have poor socioeconomic condition. Patient cannot purchase. Patient have lack of caregiver. All this lead to the non-adherence issue. So all these issues to be taken care in the elderly, and nowadays we advocate the home BP monitoring or ambulatory BP monitoring before prescribing any drug to a elderly. So this issue we have described. So you diagnose, do not diagnose hypertension only on clinic BP based, and BP variability should be keep in mind in the physician when we are dealing the hypertension in elderly, and diagnosis of the hypertension should be based at least 3 recording, and among the 3 recording at least 1 or 2 should be from the home, and make an average and apply the drug to that elderly. So secondary cause, I already discussed. When there is abrupt, patient was on antihypertensive drug and was in a controlled fashion, suddenly there is abrupt onset of hypertension or suddenly increased, particularly the diastolic blood pressure. BP was controlled with 2 drugs but suddenly lost control, or patient develop malignant hypertension. We should think about the secondary causes of this patient. And every visit, you evaluate the following structures. What are those? The heart, kidney, CNS and eye. And detection of the concomitant disease such as diabetes, dyslipidemia, hyperuricemia should be done, because these are the pathophysiological mechanisms, or hypertension, diabetes, dyslipidemia is almost same. It is a metabolic syndrome. So today the patient develop hypertension, 5 years after patient will develop diabetes, 10 years after patient develop dyslipidemia. So go on screening in a particular interval if the patient is hypertensive of the following concomitant diseases. So, and detection of the drug-related complications is must, particularly osteoporosis, pedal edema, hyponatremia, particularly if it is a summer, the tropical countries, electrolyte imbalance very common, and patients frequently admit in the emergency with hyponatremia. So there are different criteria of diagnosis of the hypertension, may differ from European country to American country, and from the Indian standard will come later on. So what should be the cutoff value for giving the anti-hypertensive medication? First, there is a controversy. What should the geriatric age group? In some of the countries they follow the 65, or some of the countries they follow the 60 years. And BP threshold for initiation of the therapy also differ from country, from the guideline to guideline. If you see the ACC's or AHA guideline, it is 130/80. If you follow the ACP guideline, it is 150. Or if you follow the European guideline, they have categorized in the 2 categories. One is elderly, one is very elderly. Very elderly means above 80, elderly means 65 to 80. For the 65 to 80 group is the 140/90, whereas very old 160/90 is a threshold for initiation of blood pressure. Target also changes. In ACC guideline, blood pressure target should be below 130/80, and ACP guideline, SBP, when we start the medicine, when the SBP is more than 150, so it should be below 150. And European guideline, systolic blood pressure target should be between 130 to 139, and diastolic between 70 to 79. So this can differ from guideline to guideline and country to country. On an average, we will discuss what is the Indian hypertension guideline. May be acceptable in the very elderly, that means is age above 80. So there are different guidelines. I cannot discuss with the lack of time. So, what is the non-pharmacological therapy? Very important, particularly the diet, salt, and exercise. So, these are the guidelines, JNC. Then it is the British hypertension guideline. Now we are coming to we follow the Indian hypertensive guideline. In older people, start with calcium channel blocker or diuretics. This is step 1. If not control and patient is one drug, then you add either beta blocker. First start with calcium channel diuretic, then you add the AC inhibitor plus minus, and then you go on adding the beta blocker as a third choice. So this is the Indian hypertension guideline. First choice should be calcium channel blocker or diuretic. Then you go on for the other. This is a very important document for the elderly. That is the expert consensus document that was published in 2011, document of the hypertension elderly. So if we summarize all the guidelines, summary is start with the small dose, increase gradually with monitoring, add next drug if not controlled, observe side effect and drug interaction and non-compliance, choice of the drug according to concomitant disease and other drugs, ordinarily calcium channel blocker and diuretic are the first line of therapy. So which agent is the best? There is so many concepts. Diuretics is a very good drug because artery is deep, you cannot dilate. But problem is the electrolyte imbalance and fluid depletion, particularly in the tropical country. Calcium channel blocker very good because artery is deep. It has some to some extent it can dilate the artery. And added advantage is the dementia prevention. AC inhibitor, particularly if the patient has concomitant illness like hypertension, diabetes, nephropathy, beta blocker is not the first choice. Single agent or multiple agent, most elderly need 2 or more drugs. If target is more than 20 systolic and more than 10 diastolic, you add 2 drugs from the beginning. Otherwise, start with a single drug. Resistant hypertension, many times that was the issues today. We fail to control the blood pressure because we have not taken care of the following issues: arterial stiffness, high baseline BP, comorbidity, increased salt intake, sedentary lifestyle, alcohol intake, poor compliance, volume overload, NSAID issues, pseudohypertension. So these are the issues that we should take care before stamping the patient as a resistant hypertension, before go on increasing the drug. And non-adherence very important because of the compelling health problem, vision problem, socio-economic condition, poor caregiver, cost. These are the issues lead to the non-adherence. So finally we are coming to the cases. First cases was physician failed to achieve the desired goal. Issue was patient was on NSAID. So NSAID means that causes salt and water retention. So NSAID should be avoided before increasing the drug dosage, and you put the patient on physiotherapy. Depression, another issue for which there may be non-adherence. So caregiver should be trained. So patient should come out from the sedentary lifestyle, good caregiver and physiotherapy. This should be applied to the patient rather than increasing the dose one after another. Case 2, possibly patient develop the hypotensive symptoms, possibly patient have pseudo-hypertension. So without understanding pseudo-hypertension, you have go on increasing the dose. So patient fall in the ground, develop the dizziness and develop the hip fracture. So take home message is multidisciplinary approach is needed to handle elderly hypertensive cases. So in elderly, you cannot go on increase the dose after dose or you can add drug after drug. You have to think in a holistic manner. If you cannot approach from the multiple aspects, starting from his social condition to compelling health problem, and if you cannot address the all aspects, you may not get the desired goal. Rather than you will get a more side effect of the drug. So understand the hypertension differently in an elderly, and that is why WHO is correctly declared world agent hypertension. Thank you.
Thank you, sir. Thank you very much for your excellent talk on how to control hypertension in elderly patients. The topic is open for discussion. We can take one or two questions from the floor.
Any question in the chat box?
Yeah. There are 2 questions in the chat box. Just check it.
Chat box. I cannot see any question. Madam,
Yes, sir. Just a minute, sir. No, sir, we don't have any
No
questions as such for you, sir. Anybody from the floor would like to ask sir any questions? Okay, if there are no questions, thank you, sir. There are no questions from the floor. We'd like to close this session. Thank you very much.
thank you.
I also thank Dr. Madhuvanti ma'am and Jyotirmoy Pal sir for their great talk.